in. Okay, before we start, shall we have a word of prayer? Kind loving Heavenly Father, we are so thankful, O Lord, for this morning. You have given us life once again, and you have protected us from harms and danger, from the effect of the typhoon. And now we are here together to have our video conference. We pray, O Lord, that you will be with each one of us. You give us wisdom and knowledge as we share with one another the lessons that we have, especially as we prepare for the final exam. Thank you for hearing and answering our prayers. Be with those who are not yet with us this time. In Jesus' name I pray. Amen. Okay. So Olaine was here a while ago. I don't know where is she now. Let's see. Okay, how is everyone?
Good, Doctora. How about you?
Okay. I'm okay. Are you
We're
at work?
lucky. We are lucky that the storm is not that
Not
strong.
bad. Yeah, that's true. That's true.
Have a blessed to everyone, classmates and doc.
At least it was not really that bad.
Yeah.
Well, so how are you doing? You're at work, Aljen?
Yes, I am, but I have requested my supervisor that I need to attend a meeting for 1 hour.
Yeah, this is a very short one anyway. I have a meeting also at 10:15.
Yeah.
Okay, so this morning, I'm sure that you have done your assignments already. I have been receiving your assignments. I'm sorry I was not able to post your scores for midterm, but I will post it after this meeting. Okay, so not so bad, but I think you can do better for the finals.
All right, Doctora.
Yeah, okay, not so bad, not really so bad. Okay, so do you have any concerns as you prepare for the final exam? I don't think you have any problem now with your requirements, right? Because you have been faithfully submitting your requirements. So that is fine. If you have not received any comment from me on your health program, that means that was acceptable. Okay. Of course, you're still writing for your research paper, no? And as I have mentioned, you can submit your requirements on or before the deadline, which is October 15, right? Okay. So, any concern?
Yes, Doc, for the final exam, will it be the same? Like, will there be a multiple choice, then an enumeration, and
Most
an essay?
likely. Most likely. I
All
have
right,
not
Doctora.
prepared yet my exam. I will be preparing my exam this afternoon and will be submitting it to the online.
All
Not
right,
later
Doctora.
than 6 o'clock.
All right. I really struggled with the multiple choice. I know it's you already have choices in it, but I really had a hard time answering those. I only got like 5 out of 10 correct, but I really enjoyed the enumeration and the essay part. So I hope it will compensate my scores.
Yeah, the enumeration is always like that because this is a graduate school. If there's an enumeration, you really have to use your brain.
Yes, I like those things.
Unlike in the elementary school where in the multiple choice, I mean, in the multiple choice, the answer is very clear.
Yes, it is.
Yeah, so the multiple choice usually takes time. The essay is not an issue.
Yes, yeah.
Yeah, because if you have digested the material, the essay is very easy.
Yes,
But
I agree.
yeah, it's always the multiple choice because you have to eliminate one after another, eliminate one after another, no?
Yeah, it is. It's like answering my board exam again. It's like a
Yes,
resemblance of
yes.
my board exams.
It's really like that, you see? So
Yeah.
the board exam type of exam is like that. You really have to think and rethink, no? Okay?
Yes.
Yeah, so wait, huh? Just one moment, please. Yeah, one moment, one moment. There is this, ano. Bye-bye. Excuse me, just one moment. Okay, so the purpose of this video conference is just really to have a short review, okay, of these units that will be included in the final exam, unit 5 to 8. Okay, so this is your, I hope that you have been reading already your material for this last unit. Okay, so I just would like to let me see, let me share my material. How can I share my material here?
Doc, I think you're already showing the PowerPoint.
Already there?
Yes, it
Shared
is.
already?
Yeah, we can see it.
Okay, I will just go to slide. Okay. Okay. So now, as I have said, this will be a very short review. Okay. So in Unit 5, this is the objective of the Unit 5. You're going to discuss the phases of postpartum, recognize and explain the three most common which are a public health concern, and be aware of the ways on how to take care of the newborn. Okay. So let me see. So again, so to meet that objective, here are your phases of postpartum. You have the initial or acute postpartum phase, which takes place during the first 6 to 12 hours of postpartum. This is usually the time where there are a lot of crises encountered during the postpartum time. And the most common cause of maternal death is usually occurring at this phase, which is the most common cause of mortality among postpartum women, which is postpartum hemorrhage. Okay, this is also a time when another cause of maternal mortality and morbidity is uterine inversion due to prolonged labor and usually deliveries in the community or outside of the hospital setting, which is too much manipulation of the abdomen, okay, resulting to uterine inversion. Then you have your subacute postpartum phase. This is the second phase, which lasts from 2 to 6 weeks, okay, beginning on the second week up to the 6th week, okay. And this is a very critical period of time for mothers who have just delivered. Time to be, though the women have already succeeded or have already outgone of the postpartum hemorrhage, this is the time wherein the onset of postpartum depression is starting. Okay, sometimes it is not well recognized, or some women may not be very aware of that, but postpartum depression usually start at this phase. Okay, and so healthcare workers usually, especially those who visit postpartum women, you will usually check for signs of postpartum depression. Okay, this is also a time wherein mastitis is also experienced among women from related to issues on breastfeeding by the woman. Okay, so infection on the breast, especially on the nipple, is usually common among this around this phase. Okay, and you have the last phase, which is the delayed postpartum phase, which usually from the, no, it should be from the 7th week, sorry, from the 7th week, okay, and could last up to the 6 months of postpartum. Okay, and though this is a period wherein the connective tissues are now returning to its pre-pregnancy state. Okay, there will now be uterine involution, and so the woman starts to become the abdomen of the woman starts to return into a normal normal, what do you call, size. And so the women now are expected to be back to their normal weight after childbirth. Okay, it is expected that women at this phase should have started already an exercise program. Okay, so in order to help in bringing back the weight into the normal pre-pregnancy period. Okay, so that is these are the postpartum phases. So we are told that the vast majority of these deaths and postpartum actually occurred in low resource settings. It is preventable, and most of the time the preventive measures are less costly. Okay, so how are we going to prevent postpartum complications? Well, if your patient has been managed properly in the prenatal period, then you will be able to recognize possible postpartum complications during the delivery, which can lead to postpartum complications. No, so again, 80% of postpartum deaths are related to obstetric complications that occurs within 1 week. That's why I said the acute phase or the initial phase is the most common phase wherein there's a lot of maternal mortality. And postpartum hemorrhage and infections are the common causes of death among these women. So postpartum hemorrhage is the #1 cause or the most common cause of maternal mortality postpartum. Okay, and it is defined as blood loss of greater than 500 ml for those who have vaginal delivery and greater than 1000 ml or 1 liter for those who are delivering by C-section, by cesarean section. Okay, so that is how we define or we identify postpartum hemorrhage. No? So what are the contributing factors to hemorrhage or postpartum bleeding? We are told that the lack of availability of medications used in the active management of the third stage of labor is one. Okay, and that's the reason why we find it most often in the rural areas. No, deliveries in the rural areas where there is no readily available medication. In the hospital, this is not a problem because all of the time there is an availability of medication that is used in the active phase of labor. Okay. Another contributing factor is the lack of experienced caregiver who might be able to successfully manage postpartum hemorrhage if ever it occurs. Okay. So that's why our lying in clinics now, we are lying in clinics now. We have experienced midwives, and they have an on-call obstetrician, okay, who will be able to, who can be called at all times whenever there is a problem related to postpartum bleeding. Of course, another one is the lack of blood transfusion services. I came to realize that this time of this how would I say, this quarter, I think that's the right word. This quarter, actually, it's difficult to find blood for transfusion. I have been receiving calls, no, here in IAS for donors because of there is no blood in the blood banks, and most of the time it takes time for if you are bringing somebody as a donor, it also needs time to prepare that donor in order for him to donate blood. Okay, I think the greatest contribution to the lack of blood transfusion, not probably the facility, but uh, blood donors or the availability of blood is because we are now competing also with the cases of dengue. No, we have a lot of dengue cases now. That's the reason why I'm receiving some calls, or if somebody wants to donate blood because so and so have dengue and needs platelet and all these things. Okay. Another one would be lack of anesthetic services, which is usually not available in the rural areas, no, and no operating capabilities in cases wherein uh, bleeding cannot be stopped. Okay, so we have to transport our patient to the nearest hospital, which for some may not be a problem to some people, but in some situations or in some countries, the countryside, for example, where transport is an issue, it's difficult to bring a bleeding woman to the hospital with an operating capability, okay, for possible removal of the uterus in case bleeding cannot be stopped. So these are some of the contributing factors to uh, postpartum hemorrhages. Okay, so we are told that there are 40s of postpartum hemorrhage. Okay, you have trauma, the tissue factor, the thrombin factor, and the tone factor. We are told that the tone factor is the most common cause of postpartum hemorrhage, followed by trauma, then by tissue, and thrombin. Thrombin deficiency as or thrombin problem as a cause for postpartum bleeding. So with the tone as a cause of postpartum hemorrhage, we are told that uterine atony or the failure of the uterus to contract is the most common cause of postpartum bleeding. And it is interesting to know, that's why we said that the availability of medicines is very, very important, because to handle the uterine atony, if there is bleeding due to uterine atony, you just have to inject medicine to cause contraction of the uterus. Okay, otherwise they are transferred to the hospital for possible surgical repair and resection or removal of the uterus. Okay, so uterine atony should not be. So you will find out that if you're going to look at, or if you're going to view postpartum hemorrhage, if there's only medicine, available medicine, then there should not be death from postpartum hemorrhage, because the only one that is necessary for that one is just an injectable medication to cause uterine contraction to stop the bleeding. Now, trauma. Trauma is the second common cause of postpartum hemorrhage, and this can be brought about by rupture of the uterus. It could be presence of a hematoma, or most likely sometimes induced by the health professional who is assisting the delivery by when doing an episiotomy by doing an episiotomy or a cut, okay, in order to facilitate passing of the head through the canal, no? So excessive, we have encountered um, bleeding from episiotomy because of excessive cut or no, or failure to identify where large blood vessels are found. Okay, and so with this, we, of course, this will be an easier, aside from the ruptured uterus. Of course, with ruptured uterus, it is a major surgical repair or even sometimes removal of the uterus. But for other contributor to trauma to the cervix, the the management is usually a minor surgical repair, no? So also another contributor to postpartum hemorrhage is uterine inversion. Okay, and this is usually considered to be a life-threatening condition, and so because it requires immediate reinversion of the uterus, no? If not, then again we remove the uterus. Okay, so we need immediate reinversion in order to stop the bleeding. How about the tissue factor? The tissue factor is brought about by retained tissue after delivery. You see, after delivery, we need to check the placenta if it is complete, okay? Because if you place it on the table in a flat surface and there are patches that are missing, that tells us that there are some tissues that are retained in the uterus. And that's why we call it a retained tissue. And this retained tissue is considered to be a foreign body to the uterus. And so the uterus will constantly contract in order to repel or to remove that retained tissue. Okay? And so unless we are able to remove the retained tissue, then that bleeding will continue to be there. So we either manually remove the tissue using our hands, putting our hands inside the vaginal canal into the open cervix, and manually remove the retained tissue. Okay, or prepare the woman for uh, procedure wherein to remove the what's this, to remove the retained tissue if we are not able to remove it manually, or to the worst, it can be the uterus can be removed as well. Okay, so another tissue factor contributor could be a placenta accreta, which is uh, not usually seen, no? The most common cause of bleeding due to tissue factor is actually retained tissue. Then you have your thrombin factor. So there is a issue on the, I'm sorry, there is an issue on the coagulability of the blood, and so we usually check, we do immediately laboratory procedures. If we fail to see if the tone is okay, if there is no trauma, there is no retained tissue, then most likely the cause of the postpartum bleeding could be related to the thrombin, and therefore we do blood testing, no, in order uh, to make certain that the bleeding is brought about by the thrombin problem. Okay, so these are the forties of the postpartum hemorrhage. So we are told again, this is just another way of showing us what is going to happen, or how are we going to approach the when there is postpartum bleeding. Okay, so you will find out there that there are different ways of there are different approaches to different causes of postpartum bleeding. Okay, but if ever this cannot be resolved through these ways that are recommended, then most likely the operating room is the last place to go for final intervention. Okay. So, any question on postpartum hemorrhage?
None for me, Doctora.
Any question there, Olen? Marites?
Wala, Doc. Naintindihan po.
Okay. If
Thank
that's the
you po.
case, let's go to postpartum depression. So postpartum depression is a form of major depression that has its onset within 4 weeks after delivery, as we have said, usually 2 to 4 weeks after delivery. Okay. It is a range of physical and emotional changes that many new mothers experience, no? And this is usually, studies have shown that this could be brought about by a rapid drop of the pregnancy hormone estrogen and progesterone after delivery that that causes their emotional how I would say imbalance, no, or variation in their emotional responses. Okay. Of course, there are also known social and psychological changes that is associated with having a baby that can contribute also to postpartum depression. Oh, what happened to my, ano, it's not moving anymore. Sorry. I think my laptop is
Naghahang yan, Doc.
hanging up for a while.
Pwede ba yan ibalik?
Sorry for that. Because it's not moving anyway. It's not moving. Yeah, it's going to die. I have some problem with my laptop this time. It seems to be going to retire ahead of me.
No. No, Doc. Do
Now
not
Muna,
going
Doc.
round and round in
do not
circles.
retire.
Please be patient. Please be patient.
It's okay, Doc. We understand.
Sorry. What's wrong? Do I have to go out of this?
But Doc, I think we can still see your PowerPoint, but it's like it's not on a slideshow.
But
I think we lost Doctora. Hi, Ma'am Marites. Where are you from in the Philippines?
I'm in Cavite. Hello, Algin.
Hello.
Are you
I'm also,
Filipino?
yes, I am. I'm from Silang.
Silang. Silang ka lang pala eh.
Opo. Ayan, dyan na po ata si Doktora. Nice to meet you po, ma'am.
Nice to
And
meet you, Algin.
also you, Olin, hello. Nice to meet you again.
Okay, nice to meet you, Elgin.
Can you see my slides now?
Not yet on my part, Doc.
Not yet, Doc.
But we can see
No.
you.
Huh?
We can see
We
you,
can
but
see you, Doc, but you never share your slide yet.
Where's my share slide? Ah, yay.
the green button down there, Doc.
There.
Share screen.
Yeah. Share screen.
Yeah, ready.
There. We can see it now, Doc.
Ready. I hope it will not give me another problem. Okay, at least we're back. I will be in a hurry so that this will not die. Sorry about. So you are here, your postpartum depression risk factors. You have a mental illness before pregnancy, mental illness including postpartum depression in the family. So there is a history of postpartum depression in the family, postpartum mental disorder after an earlier pregnancy, usually social issues like conflict in marriage, loss of employment. There was a history of loss of a child in the past, okay? And stress from changes of the routine of being a mother, feeling fatigue because of a broken sleep patterns, mother, especially when they are breastfeeding, no? So the sleeping pattern may change. Feeling less attractive physically and sexually, physical changes after delivery, no, because they become fat, no? So they feel depressed that they look like that, and probably caring for a child, and so they cannot care for themselves, and they have this negative feeling that they are looking ugly now. They have a child, okay, and of course they are tired after giving birth and onward, especially if there is no support from the family. There, in addition to that, they have this problem on the as a result of the delivery, like soreness and pain in the perineal area. Now that they have a child, in the past probably they were working mothers, no, and now they have a child, so they have now a feeling that they are being trapped in the house, okay, and of course, if there are no support, they will probably feel overwhelmed with responsibilities at home. I don't know, I can just imagine these women who delivered a new baby, and there are still 4 other kids to take care of, no? It's a common picture actually, no? In most communities, no? In the countryside, not probably in the city, because it's difficult to have a child in the city. Most people living in the city doesn't even want to have a child, no? But in the countryside where I called that in my class the do re mi fa sol children. So many children, one after another, no? So do re mi, one after another, one after another. So many children. Oh, I can't imagine how they handle this number of kids, no? And here's a new baby coming in. The mother will really be overwhelmed with a lot of responsibilities at home. And so these are common contributors to postpartum depression. Okay. So what is the most important management of postpartum depression is really awareness, no? Awareness of what? Awareness of the symptoms, no? It's okay to be, most mothers will be, most families will be very, very happy of having a child at home because child is always, what's this, a welcome one. But symptoms like sadness, overwhelm of work, fatigability, not able to eat, lack of sleep, isolation, and all those things. If these symptoms goes beyond 2 weeks, we should be worried about it. No, we should be worried why this woman is having the symptoms. No, so we have to educate our postpartum women about the symptoms of postpartum depression. Okay, because they need to be aware of that in order that people can help them in that kind of situation. No, so postpartum depression is sorry, postpartum depression awareness is a most common thing. We have to take care of that woman. If that woman is unable to function normally, no, sleeping all the time, of course she might be fatigued. But if she just sleep all the time, all day long, not even caring for the newborn, okay, then we have to be worried about her. Okay, if she cannot cope up with other everyday situations, then we should be worried about that one as well. Why do you keep on clicking there? She has thoughts of harming herself or her baby. Okay, is another thing that we need to be looking at. Okay, and if she is feeling extremely anxious, scared, and panicked most of the day, then we need to bring her into an awareness that there is something wrong with her. Okay, and that's the only way we can help this woman, this postpartum woman. Okay, so again, if you're going to look at the Ratos model of prevention for postpartum depression, you will find out that what is common in this model is really education. Okay, so this is the role of a public health worker, no, to educate the woman. Usually educate the woman during the postpartum, the prenatal period about postpartum depression. Okay, so you will find out here, this is actually a gradation of the form of education that we need to do, okay, in order to avoid postpartum depression. No, so it's a progressive step-by-step education program for pregnant women. Okay, so you will find out here that there is an education to lower the stimulus towards pregnant women, like telling her about the physiological changes during pregnancy. No, then you go to the next, the how she's going to cope with the changes, and that includes spiritual coping, for example. Then you go to the next phase. You have there the self-care for her, the role function, No, the need for interdependent response, interdependent social needs to be met. And also you will find out there at the last that there is the need for the support of the husband in order to prevent the postpartum depression. Okay, so you will also, what is also common among these, what is also common in this model aside from education is that it emphasizes the need of social support. Okay, so social for us public health care workers, our role is really to educate these women and to emphasize that there is a need for a support. Okay, support from family members, support from friends, support from the community, in order to avoid postpartum depression. Okay, any question on that, on postpartum depression?
No, doc. It's okay.
So we come now to obstetric fistula. Obstetric fistula is a common problem. It's a complication that occurs during third stage of labor. No, so it occurs in the stage of labor, and this is actually brought about by prolonged labor. One is really prolonged labor, and when there is a head and pelvic bone disproportion during the time of delivery. So in obstetric fistula, due to prolonged labor and a disproportion in the head and the vaginal canal, okay, then there is the tendency to make a tear, okay, a tear between the on the bladder and a tear in the rectum. So therefore, when there is a tear brought about by this in the third stage of labor, then this tear creates a connection. Your material says it creates a hole, no? So it creates a connection between the bladder and the vagina, or the bladder and the vagina and the rectum, thus causing so-called obstetric fistula. If you're going to look at this picture on your right side, upper right side, you will find a fistula between the rectum and the vaginal canal, and we call it the vaginal fistula. And unfortunately, this can be repaired actually, but in many cases, especially in the rural area, countryside rural areas where there is not much of the how would I say, assistance, or when there is a problem or lack of facility to facilitate identification of that fistula, then where's that? Then this fistula can create some social issues actually, because unrepaired fistulas can bring about some health problems. Like for example, in a enterovaginal fistula, you are unrepaired one, can result to continuous leaking of the content of the rectum. Okay, so you will find that woman will continuously leak the fecal matter. Okay, so the fecal matter continues to leak outside. No, how can you imagine this woman? You're sitting with this woman who is continuously leaking his fecal matter. How would you feel about that? Okay. And then on the other side, you are going to see here a bladder, a hole between the bladder and the vagina. Okay, because of the rupture of or a tear or injury into the bladder during the delivery. And so you have there your vesicovaginal fistula. and this woman will continue to leak urine all throughout the day through the vaginal canal, okay, instead of the urethra. Okay, so obstetric fistula is a hole in the birth canal caused by obstructed labor, as I have mentioned. It can largely be avoided by delaying the age of the first pregnancy, especially early age pregnancy. It can be prevented by the cessation of harmful traditional practices, like, for example, what's this one? Female genital mutilation, which is a practice in some cultures, and by timely access to quality obstetric care. Obstetric fistula can largely be avoided also by delaying the age of first pregnancy, by the cessation of and to for timely access to quality obstetric care, as I have mentioned. So obstetric fistula still exists because healthcare system failed to provide accessible, quality maternal health care, family planning, skilled care at birth, basic and comprehensive emergency obstetric care, and affordable treatment of fistula, which is, as I have said, the 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 basic management of fistula is just to repair it. Okay, so what is the cost of having obstetric fistula? It can create physical problems, psychological problem, and it has a medical cost. So for physical problem, as I have said, continuous leaking of urine or feces is common. It can also result to nerve damage to the lower extremities after a multi-day labor of squatting in a squatting position. And because of the continuous leaking of the urine and the fecal matter, it can lead to urinary tract infection and even dehydration. For psychological impact of obstetric fistula, you will find out that it can result to marital problems, divorce, separation, abandonment by husbands and other family members, and leading to loneliness and shame. Yeah, because you see, many of these women struggle with severe depression also due to isolation. No, so it has a psychological impact on women. It has also a medical cost because of if the management cannot be done in the lying in, for example, or a smaller hospital, and so that woman can have the repair in a more adequate, well-equipped hospital, and therefore it has a medical cost. And with that medical cost, also is another problem is that there is also loss of productivity because this woman will not go back to work because of the stigma and the shame that she undergoes because of the obstetric fistula that resulted from her delivery. Okay, so for postpartum care, it is very easy for women. They just have to we need to remind them that they have to get plenty of rest. They have to seek help when they're not emotionally stable or they have some issues. They have to eat healthy meals and do exercise program as soon as they are capable. The exercise program may vary according to the capability of the woman. She may not immediately go back to the strenuous activity that she used to have, but she can do a gradual progression of the exercise program. Okay? Any question on postpartum?
Oh, good.
Okay. Now let's go to unit 6. So you read your unit 6, okay? The objectives of unit 6, of which I will summarize here in short. Okay, so you have reproductive health is a condition in which the reproductive function and process are accomplished in a state of complete physical, mental, and social being. And it implies that people are able to have a satisfying and safe, and that they are capable of reproducing, and the freedom to decide if, when, and how often to have sexual activity. Reproductive health care is defined also as the entire set of methods, techniques, and services that contribute to reproductive health and its well-being through prevention and solution of various problems related to reproductive health. Okay? And that is in your material. So what are the reproductive rights? According to the Beijing uh, guidelines and policy brought about during that meeting in Beijing on reproductive rights, here are the reproductive rights. Okay, so right of all couples and individuals to decide freely and responsibly the number, spacing, and timing of their children. To have the information, the right to information and means to do so, the right to attain the highest standard of sexual and reproductive health, the right of all to make decisions concerning reproduction free of discrimination, coercion, and violence, and the right to receive education about contraception, sexually transmitted infection, and freedom from coerced sterilization, abortion, and contraception. So that is how that is the couple's reproductive rights, or a family's reproductive rights. So family planning is one of the pillars of safe motherhood, aside from antenatal care. So family planning, and so this unit deals with family planning as one of the pillars of safe motherhood. Okay, so here are the family planning advantages, and I think everyone knows about this. Sure, you are familiar with that. So for the mother, it enables her to regain her health after delivery. Okay, gives enough time and opportunity to love and provide attention to the husband and the children. It gives more time for her family and own personal advancement. And when if suffering from an illness, it gives enough time for her for treatment and recovery. How about for fathers? So for the fathers, it lightens the burden and responsibility in supporting his family. It enables him to give his children their basic needs. It gives him time for his family and own personal advancement as well. And again, if he has been having an illness, there will be enough time for treatment and recovery. So you see, a good example that I usually give is this on family planning advantages. If you're going to buy one pizza, okay, if you're going to buy one pizza and you have only 2 kids, then each one of you will get a bigger share, right? But if you buy one pizza and there are 8 of you, you have 6 children plus you and your husband, then you will get a small piece of the pizza. Some even said it just melted in the mouth, doesn't even reach the stomach. Yeah, because it's so small. It's so small. It doesn't, you don't even feel the presence of the pizza in your mouth, only in your mouth, but not until the stomach. Okay. So for the children, we are told that when there are only few children, then the children are usually healthy because the mothers are also healthy, and they will get attention that they need, security, love, and care that they deserve. Okay. So again, you look at this, the planning services. What are the coverage of the planning services? So we are told that these are some of the planning services that are part of the family planning. Okay. So about spacing of the children, because we are told that reproductive health includes spacing of the children. We are told that The recommended spacing for children is about 18 to 24 months after a full-term delivery before a woman again begin to conceive. Okay, not 18 to 24 months become before she gets another child. Okay, but 24 months, 18 to 24 months before conceiving again. Okay, so 24 months, then she can start being pregnant once again. So child spacing, why it is important? Because this, for the mother, it is the time to recover from birth. She'll be able to regain her nutritional needs that she lost during the pregnancy. This will also be give her enough time to regain her pre-pregnancy weight. Okay. How about for the newborn? For the newborn, the advantage is that the child could be better fed, and there will be a better parent-infant bonding established if there is enough spacing of children. Okay. If we are going to look at malnutrition, we are going to see that one of the cause of malnutrition, underweight children, is actually the presence of when the mother becomes pregnant again while she's still breastfeeding the previous child. Okay, so child spacing is very, very important. So in family planning, these are the factors that affect one's choices: the age of the woman's reproductive stage, whether she is just starting to reproduce her family, or she is already she's already done with her desired number of children. Okay. How effective is the method? The woman's health status. Is she, what is the status of this woman? Is she hypertensive? Does she have other issues? No. Women who have no plans anymore to have children in the future because, as I have said, they have already reached their desired number of children. Looking into the side effects as well, and other personal consideration. So you will see that in dealing with family planning services, and family planning choices of methods, you cannot, there is no really standard. No, it does not follow a one size for all. No, because of these varying needs that affects choices among our women. I mean, not only women, but couples in relation to family planning. Okay, so here is this is also found in your material. It tells us about the effectiveness of different contraceptive methods, from the least effective to the most effective. Okay, so what are barriers to family planning? You have there your cultural barrier. This is usually seen among the hesitancy of males to participate in a family planning program because of lack of male focus in family planning methods. They say that, oh, family planning, this is because this is related to conception, therefore that's my wife's business, so she will be the one to choose what is the right, or what will be the appropriate contraceptive method. Okay, societal pressure on women also is another one. Among the Asians, especially among the Asians where there are Muslim communities, the need for a boy. No, so unless there's a boy, the mother is able to bring a boy to the family, then she continues to become pregnant until a boy comes into the family. Okay, so that is one. And of course, sometimes if one child dies, then there's the need to replace the child who have died. No, there's also an educational barrier. lack of education about the side effects of contraceptives, and also there are some myths that need to be corrected in order that causes that prohibits participation in the family planning program. There are also financial barriers, for example, like if the woman prepares to have sterilization and they have to go to the hospital and there's no money, then that is an example of a financial barrier. And you have also the so-called structural barrier, wherein the family clinic, the clinics may be very far away, no? So they need money. That should also be a financial barrier on that side. And so they cannot go there, or it's too far away that they feel it to be inconvenient to be going there for that family planning services. Okay. In your material, you will find out reasons why there is low acceptance of reproductive health among men, and I leave that to you. Okay. So in approaching as a health educator, this is the approach that was recommended by the World Health Organization and other organizations who are working with family planning programs. And they said that this is considered to be the best approach, the gather method. Okay, so I think this is very, very self-explanatory. So you just look at that one. Okay. So things to remember in reproductive counseling: we have to treat each client well, interact with them, ask them their needs, what are the preferences, okay, and tailor information to the client, avoid too much information, provide a method that the client wants, and help them to understand and remember the instruction. Okay. I'm running out of time, but I want to give this example to you in this section on helping the client understand and remember the instruction. Okay. Understanding is very, very important. You know, I have a case in the past, many years ago, when I was working in the government, and I was younger at that time, and I was in the family Thursday is a family planning day, and so most of our clients will come to the health center for the family planning services. And so after gathering the information, the couple wanted to have they choose to have condom. Okay. And so sometimes it's for a woman. It's sometimes embarrassing to illustrate the use of the condom. Yeah. So I was telling the couple, okay, this is how you use the condom. Okay. When you are ready, when the male is already ready, no, is the penis is already erected, then you put, before the penis will be erected, you have to put the condom like this. You know, you have to put it here, put it like this. Okay. And did you understand how to do it? And the male said, yes, doctor.
Yes, Doki.
Okay, it's going to be like this. Okay. So
Ending inventory.
after a month, the wife came pregnant. Okay. And I said, so did you follow my instruction? Did you still do the condom? He said, yeah, doctor, we followed very well your instruction. We did what you told us. And so, oh, okay. So I was thinking, oh, so maybe there is a failed mechanic. There's a problem in the condom, no? Because it can happen. That's why the condom, the effectivity of the condom is very, very low, no? And so I said, so Can you tell me how you do it? How did you use the condom? Because this is the first time to use the condom. And so the husband said, well, according to your instruction, and it's already like this, I have to put the condom like this. And so, oh my, that's why your wife get pregnant. Because you did not put it into the penis. You put it there. We put it there in the finger, So that's why I said this was really a lesson for me, very big lesson for me, that we need to help the client understand what we have been what is the instruction, and remember how to do it. I cannot forget that lesson. That was a lesson for me, that we have to be very careful about how we do the instruction. So he said, oh, doctor, I put it there. I put it there. And it was a laughing thing, for me. I was really laughing at that. He said, oh, so you were doing like that, like that. It's funny, but we have to really be very careful about our instructions. Okay. So these are some things that we need to remember in the reproductive counseling. I'm very, very sorry. In your objective, you're going to look at the church statement of birth control, but I don't know what happened to me. I cannot find there in your material. So please look at this. Okay, this is the statement of the church regarding birth control. And in case, I put this actually because sometimes the church members will ask about this one. So please review this for Olen. Okay, I think Olen and Ruben should put this into their hearts, and the others can read that one. Okay. Okay. Actually, we call it an official nature statement on birth control, but actually, it applies also to other people because it is actually related to creation, reproduction. Okay. So I think that's the end for that chapter, unless there's a question. Any question?
None on my end, Doc.
Doc, I just want to, our course is very relevant actually in the pre-marriage couple. Just because of this, I don't know, in the SDA churches, before they will go to marriage, there is a seminar that about family planning, preconceptions thing, so that the married couple, because in the Catholic Church, there are already a pre-cana seminar about handling the relationship, but in the maternal and child issues, it's not tackled it. Even in the school is in the high school, it's already about the condoms and contraceptives, but in other part about the maternal nutrition, I don't think so. It's already tackled in our country.
Actually, with the Seventh-day Adventist, Olaine can speak for this also. Most of the pastors are the ones, the pastor who is going, or the pastor couple who is going to officiate a wedding, they do the marriage counseling. And there is what they call that one now? There is we need to meet the couple. There is a series.
Oh, it's a series of seminar.
Yeah, there's a series of seminars before officiating the wedding.
That's why, because I told my staff here, my staff is a nutrition dietetics also. I said, maybe because of this, we need to go to the churches of Catholic and we will offer our services so that we can.
Actually, there is what's the statement? We have a series of seminars before the wedding. That's why couples who wants to be if for example, like last Sunday, somebody came to our house because they want my husband to officiate the wedding. It will be on December something. So we will start having the seminar every Sunday until the wedding time. So there's already what do you call that one?
It's just like maternal.
There's already prepared. There's already a prepared. What's this?
seminar.
Like seminar. Yeah, and
Seminar.
activities for them to fill up for pre-marriage counseling by the pastors.
Because
So
in our barangay doc, that you see in there's a center in our barangay. I never heard just like that and offered the services like that. That before they were going to marry, or the children or the adolescents, especially adolescents nowadays are
Yeah.
early in marital sex relationship. So I
yeah.
think this kind of maternal and child nutrition issues should be tackled in the high school and even in college for the preparations or for knowledge or preparation in marriage, so that they will not, you
Yeah.
know.
Actually, in the Adventist Church, the Adventist Youth Program provides that information
I think
for the young people.
I think I can
It's
use
a part of their curriculum.
Oh, that's very good.
Yeah, it's a part of the Adventist Youth curriculum. Yeah.
That's very good.
So that's the word that I was looking for, curriculum. So for premarital counseling, we already have a prepared curriculum.
Very
If they're
good.
going to marry. So this first meeting, this is what we are going to tell. Second meeting, this is the one. Until you reach the last meeting. The last meeting is talking about how many children do you want to have? So you ask the husband, because the husband may say, I want 5, and the wife said, I want 3. So you have to talk to them about that one. Okay? Who will take care of your child? When you get a baby, who will take care of your babies? Your mother-in-law, your mother. So we need to pre-arrange that one ahead of time. So
Maybe
that's how we do it.
maybe only 70 Adventists is the one has that curriculum.
Yeah, we do have a curriculum.
Because I go around, I'm a speaker in different religions. I never saw this kind of curriculum for a marriage.
Yeah, we have a curriculum
That's
every
very
Sunday. Actually, my husband and I, we usually meet them for 10 times. Yes, Olaine. Oh. So yeah, so we have that curriculum, premarital counseling curriculum for the pastors, no? And of course, the government requires that. In the Philippines, the government requires that premarital counseling before getting the certificate of marriage, application for weddings. So
in the application of wedding doc, I saw their curriculum is not really about the nutrition. It's more on the counseling side, more on the psychological and emotional childs when they're getting marriage, that they should not be, never be broken. But but in the scientific side, there's no like that very specific, that if you are if you get pregnant, your child become in the embryo from zygote to fetus. There's no
that's why, because in the curriculum, in the premarital counseling curriculum for the pastors couple who will be counseling who will be officiating weddings, for us, we tackle conflict management. There's a curriculum on conflict management, handling differences, like for example, preparing for separation from parents, for example, and so forth. Then you go into what to do, preparation for parenting, and so forth and so forth. Yeah. Okay. So that's how we handle it. And the rest, the rest are for the adolescents. They are taken care of by the Adventist Youth Department, of which each of the Adventist Church adolescents should be a member of the Adventist Youth Movement. Okay.
Very nice.
Okay.
Very nice curriculum.
So now you come to unit 7, neonatal death, neonatal period, okay? So early neonatal period is age 0 to 6 days, of which 3/4 of the neonatal deaths occurs, and you have your late neonatal period, which is 7 to 27 days. Okay, and again, you have there your most common cause of neonatal death, which is prematurity, followed by infection and birth asphyxia, as mentioned in your material. Okay, this has never changed. The percentages have changed, but the reasons for neonatal mortality remains to be the same. Okay, it's prematurity, infection, and birth asphyxia. So for birth asphyxia, this is how we handle. This is how we determine whether there is a need for resuscitation or not by using the APGAR scoring. Okay, so each of the description over there have to be described and be graded, and that after summarizing the grade, then you determine whether that child is okay, or that newborn is okay, or that newborn needs to be watched for, or the child needs to be in the what's this, intensive care unit. Okay, so birth asphyxia, for example, is determined we know that just few minute of not able to have oxygen in the brain can bring about complications, and therefore complication possibilities of birth asphyxia can be determined by the following factor: how long the newborn does not get oxygen, how low the level of oxygen is, and how quickly the right treatment is given. So these are the common factors that needs to be determined. Okay, that's why we need to address this problem immediately. And then you have now your newborn care goals: to establish and maintain and support respiration, to provide warmth and prevent hypothermia among the newborns, to ensure safety and prevent injury and infection, and to identify actual or potential problems that may require immediate attention. Okay, so the World Health Organization and the UNICEF recommended that in order for us to have successful or a healthy neonate, there is a need for skilled attendance at delivery, care during home delivery, immediate postpartum care, and be alert of danger signs. Is it okay for me to send this PowerPoint to you?
Yes, Doc.
Yes, Doc. Yes,
Sorry,
please do
they are
so.
calling for me for a meeting.
Yes, please, Doc, do send us.
I will send this material to you, okay?
All right,
Okay.
Doc, no problem.
Can we end our meeting now? Sorry,
Yes, Doc.
Sure, sure. It's
sorry
okay.
about that.
Doc.
Well,
Okay.
Thank you so
thank
much.
you, Doc, ha. Thank
So
you.
I'll send this to you and prepare yourself for the final exam, okay?
All right, Doc. Thank you very
Okay.
much.
Thank you very much for
Very
being
much.
here with us this
God
morning,
bless.
and
God
God
bless you,
bless
Doc.
for the exam.
Thank you, Doc.
Thank you,
Okay.
Doc.
Thank you, Doc.
Bye-bye.
Bye-bye.
Bye-bye. Sorry.